over to the next session. And for this, we have chairpersons, Dr. Arun AC, who is Associate Professor at Vellamal Medical College in Madurai. We have Dr. Roshan Aggarwal, who is Consultant of Gastroenterology at Apollo Hospital in Guwahati, and Dr. Balaji, who is a consultant at Manipal Hospitals in Bengaluru. Over to you, chairpersons.
Thank you, sir. Am I audible?
Yes, you're audible.
Thank you, sir. Next session is a very important topic in present times, that is COVID vaccination in IBD. I would like to invite Dr. Deepak Parakkal. He is Assistant Professor in the Medicine Division of Gastroenterology, Washington University School of Medicine, St. Louis. Sir, please. Deepak, sir, please.
Thank you, Arun. Thank you, chairpersons and organizers, for the invitation to speak on this topic. Let me just see if I can bring up my screen. Okay. So thank you again, organizers, for allowing me to speak on this topic. I've really enjoyed the talk so far. I've learned a lot. So the topic I'm speaking on today is COVID-19 vaccinations in IBD. Sorry, let me just financial disclosures. I'm going to start with a general slide just for orientation, since we have many vaccines out there. So starting from the left-hand side, top left, you have the inactivated vaccines, of which primarily you have Covaxin, which is available in India, which is an inactivated vaccine that contains SARS-CoV-2 viruses that are chemically inactivated. Then on the top right-hand side, you have the viral vector vaccines, of which again you have two, the Johnson & Johnson vaccine as well as the AstraZeneca vaccine. The AstraZeneca vaccine, of course, also known as the Oxford vaccine, also known as Covishield in India, is basically utilizes a different virus modified to express the S protein of the SARS-CoV-2 to elicit antibody response. And then you have the mRNA vaccines, of which you have the Pfizer, BioNTech, and Moderna available worldwide, which consists of mRNA packed in lipid nanoparticles, again with the idea of expressing spike proteins and then eliciting response. So with that orientation, I'll then switch over to another slide before starting the talk. This is just to orient to the idea of B cell response to vaccination. This is important because we keep talking about antibodies, measuring antibodies. So just to orient, on the left-hand side, you have an uninfected individual who receives doses 1 and 2. On the right-hand side, you have a previously infected individual receiving doses 1 and 2. So as you will see here, in the uninfected individual who had naive B cells and gets primed with the first dose to produce plasma cells and memory B cells, and then further gets primed after the second dose to produce more activated plasma cells and memory B cells. And as you'll see here, the magnitude of response increases after the second dose. The neutralizing activity also increases, and more importantly, the neutralizing breadth increases, which is significant given all the variants of concern that are now popping up. Contrast to this, if previously infected with just one dose, you start seeing the previously present plasma cells and memory B cells from the infection and recovery further getting primed with the vaccination to produce fully primed plasma cells and memory B cells with full magnitude, activity, and breadth. Here, as they show in this cartoon, no further increases in the neutralizing activity or breadth is seen in studies after the second dose, specifically in individuals who are already infected and recovered from the initial infection. Now, some of this, I will say, may or may not be any more true with the Omicron variant, but this cartoon and the data was with what we had from the previous variants. So with that, the overview of the study of the talk today is that I'll be talking about data from Coveripad and various other current studies. I'll talk about the safety of vaccines against SARS-CoV-2, specifically in IBD patients, and then the role of booster doses among patients with IBD. So the Coveripad study was led by myself along with my wonderful colleague Alfred Kim, shown here from rheumatology at Washington University in St. Louis. The first paper data is shown here. At that time, we had about 133 participants with what we call as chronic inflammatory diseases, CID, which is a catch-all term for IBD and various other autoimmune diseases. We assess patients 2 weeks prior to and then 20 days after the second dose of vaccine. We measured their anti-spike antibodies and also looked at neutralizing antibodies. Now we have enrolled about 400 patients, but at that time we had 133. About 32% had IBD and 29% had rheumatoid arthritis. The key results shown here, overall results shown here, clearly patients with CID had lower geometric mean antibody titers as well as neutralizing antibodies compared to immunocompetent controls. On the far right, you see what's an upset plot, which really is showing the various drug combinations that the patients were on at the time of the vaccination. And combinations of therapies are shown where a vertical line joins two dots for the drugs. Those are that is a patient on two different drugs at the same time. Our drilling down, our key findings were that glucocorticoids definitely reduce the immunogenicity, as shown here. With my cursor, patients on prednisone had lower antibody titers as well as neutralizing antibody titers. Of course, these patients were not just on steroids. Again, here the upset plot shows that they were on various different combinations in addition to being on prednisone. Here are the patients on prednisone in our study. TNF alpha inhibitors, at the time of the publication, we only had about 39 patients. At that point, we did show that the antibody titers were lower compared to immunocompetent controls, and the neutralizing antibodies were also lower compared to immunocompetent controls, but similar to the other patients with CID. Again, some of these patients on TNF alpha inhibitors were not just on an anti-TNF, but also on other combinations, as shown here in the upset plot. Janus kinase inhibitors, similar story, lower antibody titers and lower neutralizing antibody titers compared to immunocompetent control shown here. Again, the patients on JAK inhibitors were very few at the time of the first paper and also were on combination with certain other medications as shown here in the upset plot. Antimetabolites, again, lower geometric means for antibody titers and neutralizing antibody titers compared to immunocompetent control geometric means. Again, these were patients on combinations with other therapies or on monotherapy. But the good news, at least from the first publication, was that anti-integrins, as shown here, and anti-interleukin 12/23 agents did not seem to impact antibody response or neutralizing antibody titers. Again, these were small numbers, but reassuring data. Next, looking at the Clarity IBD cohort, of which Professor Sebastian and others are now a part of, coming from various centers in the UK. The primary outcome here was to measure the anti-spike antibodies 3 to 10 weeks after the primary vaccination. The antibody responses in our case were measured using an in-house assay versus in this study was measured using a Roche anti-spike immunoassay. I make this point because different studies are using different lab assays, so it's a little difficult to compare between studies. And they had a threshold as shown here for what was considered an adequate titer. The key take-home point from the first study published in Gut was that patients who had just one dose of Pfizer or Pfizer vaccine, which is the BNTB162b2, or the AstraZeneca, Oxford, or in India known as Covishield, the Chad OX1 vaccine, one dose was not enough to elicit a significant antibody titer in patients who were on infliximab, but certainly seemed to elevate in patients on vedolizumab. Now, patients who received a second dose or had a dose after having recovered from infection did mount a response in the adequate threshold when they were on infliximab. At the time of the first paper, they did not have enough patients with second doses on the AstraZeneca vaccine, and hence that data is not shown here, but subsequently it's coming out in their follow-up manuscripts. The take-home message from this next figure is that immunomodulators did have an impact on antibody responses as shown here. Going from left to right, the first panel covers the Pfizer vaccine. The second panel covers the AstraZeneca or Oxford or Covishield vaccine. As you can see here, infliximab, when used with an immunomodulator, had the lowest percent seropositivity. So along the y-axis here, you have the percent seropositivity status. And then monotherapy infliximab followed by vedolizumab with immunomodulator therapy. And finally, vedolizumab monotherapy had the highest percent seropositivity for both vaccines. Now, the other findings shown in this study were that patients who were older and were smoking had lower fold change responses, while those who had non-white ethnicity had higher fold change response. Another manuscript that was recently published out of this cohort looks at the impact of drug levels on seropositivity and magnitude of antibody response. If you look at the figure on the right, in pink, you have those with detectable levels, and in blue, you have undetectable levels. Within group comparisons, as shown by my cursor here, for adalimumab and infliximab were significant for percent seropositivity. In short, patients who had undetectable infliximab were more likely to be seropositive for SARS-CoV-2 antibodies, as well as similar for adalimumab. However, the magnitude of SARS-CoV-2 antibodies was higher in patients with undetectable infliximab, and they did not show this as being significant for patients on adalimumab. For vedolizumab, clearly the drug levels did not seem to make a difference, as shown here. Looking briefly at Preventcovit, this was another study mainly coming out of the Crohn's and Colitis Foundation, but also led by Dr. Kappelman and group. At the time of the first publication, they had about 317 patients, all IBD. Antibody testing again was variable, a median of about 64 days after the second dose. They again looked at SARS-CoV-2 anti-spike antibodies, again using a different assay, in this case the LabCorp, a different cutoff for what's normal, and they excluded people with prior infections. Largely a reliable message and a good message that about 95% overall seroconversion was seen across patients. Of significance was that patients who were on a combination of anti-TNF and an immunomodulator had the lowest seroconversion. And also importantly, steroids seem to make an impact on both the mean and the median antibody levels. And this, as you recall, was also shown in our study, where steroids clearly impacted the response. I searched actually pretty significantly both on Google Scholar as well as PubMed, and I happened to find only this one study, and I'm happy to see if others have other studies they have seen, specifically looking at the impact of Covaxin in patients with autoimmune diseases. Now, Covaxin, the scientific name is the BBV152, and this was a study by Dr. Padmanabha Shenoy from India, specifically Kerala, where he looked at 136 consecutive patients with rheumatic diseases and without a prior COVID-19 diagnosis. About 102 had what he called as autoimmune rheumatic diseases, called as AID, and 34 with non-AID diagnosis. He measured anti-spike antibodies about a month after the second dose of either the Covishield, as it's called in India, the CHAD OX1, or Covaxin, which is BBV152. Now, I'll bring your attention to the figure here. Along the x-axis, you have the non-AID vaccines and the healthy controls. And then along the y-axis, you have the log antibody titers. In orange or red, you have patients who received Covaxin, and in blue, you have patients who received Covishield. And you can see clearly here, and again, I'll say that these are a small number of patients, especially the ones who received Covaxin. But clearly, you can see that the patients who received Covaxin had lower mean geometric mean antibody titers compared to patients who received Covishield. Now, the text again shows this, that about 69% of those who received Covaxin had detectable antibodies compared to 95% who received Covishield. So the conclusion was, as stated here, antibody titers were higher in Covishield patients compared to those who received Covaxin. Again, I would argue small numbers, but this is the data that we have so far. bringing your quick attention to actually a systematic review that I was involved in along with Dr. Sharma, Professor Sebastian, and mentees, Doctors Jenna and Mishra, as well as others, primarily driven out of PGI, where we looked at all the studies at that point in time and drilled down to about 25 studies for analysis of antibody response in patients with various immune-mediated inflammatory diseases. The overall news was good. Patients with IBD had about a 95% seroconversion, which is similar to, as you recall, the data from Preventcovit. Drilling down further into the medications, however, some concerns. Patients with steroid exposure down to 78% seroconversion. Patients on Janus kinase inhibitors about 84%. Patients specifically on infliximab about 89%. As a class was around 94%, but obviously most studies had published out of infliximab in this across the various cohorts at the time of the publication. We further looked at combination therapy and showed that monotherapy was 60% more likely to produce seroconversion compared to combination therapy with of a anti-TNF with an immunomodulator. Switching gears slightly to safety of vaccines, there are only two studies that I could find so far out there. The first one is the Corel IBD study out of Cedars-Sinai and other groups. They looked at about 246 IBD patients after at least one dose of mRNA vaccine. About 57% received Pfizer, rest Moderna. Overall, the adverse event frequency would look kind of high at 40% after dose 1 and 62% after dose 2. However, if you look at it further, they are looking at a large number of symptoms, not all of them being serious or incapacitating for the patient. So to walk you through the figure, you have the various symptoms in two panels, left and right. Each panel is further divided into side effects after dose 1 and dose 2. Furthermore, each panel is divided in purple, patients who are on non-immune modifying therapies, and in green, on immune modifying therapies. Additionally, the stacks, as you can see here, the darker parts of the stack are the more severe symptoms. So just on a naked view of the figure, you can see that patients had more symptoms if they were on non-immune modifying therapies and also had more severe symptoms on those. And that is really what they found in the study, that advanced therapy status or immune modifying therapies had less side effects, and increasing age was also associated with less side effects. We found somewhat similar data in 441 participants, including the controls, and this is a manuscript that's under review but close to acceptance. And you can see here patients with CID and healthy controls. Along the y-axis, you have the predicted antibody titers, and then you have the symptoms being tracked for both the groups. And you can see here clearly there's a trend that more symptoms and greater the titer. And this is really what we found, that patients who had more first dose severity or had more number of symptoms after the second dose seem to have a greater increase in predicted antibody titers. And also there were some specific symptoms that seem to mediate that. This is novel data because this has not necessarily been shown previously in immunocompetent controls. And then now finally switching gears in the last few minutes to look at the booster data. So the question is, we've given the 2 doses of the various vaccines. Do we really need to boost our patients further? Well, now this is data from the CDC and from March through July 2021. Mind you, this is before the Delta variant happened and clearly before the Omicron. What you can see here clearly is that the vaccine effectiveness shown on top among patients with immunocompromising conditions drops to about 63% compared to about 90% in patients without immunocompromising conditions. And this is vaccine effectiveness against hospitalization, something we really care. Not necessarily whether it prevented the infection, but it actually prevented hospitalization. So clearly it drops, and it drops further if once you go out to 13 to 24 weeks from the second dose of the vaccine. So the darker shade of blue is further out from the second dose compared to lighter blue, which is initial period after the second dose. So this was shown further in a preprint from Clarity IBD group, where they showed a decay in antibody titers for both vedolizumab and infliximab about 14 to 18 weeks after the second dose of the vaccine. But clearly, in green are the patients in infliximab where that titer decay is way more acute than in orange, which are the patients on vedolizumab. So clearly a concern for patients on infliximab, happening about 14 to 18 weeks after the second dose of vaccine. And this is patients who received either the Pfizer or the um, um, Pfizer on top, or the AstraZeneca or Covishield vaccine on the bottom. Now, it's also shown by us in this follow-up manuscript where we looked at anti-spike antibodies and neutralizing antibody titers. And then we ran this in the lab in terms of its ability to, against the variants, the standard variant and going down all the way down to the B1617.2, also known as a Delta variant. And and it's a busy slide, but I'll mainly have you look at the heat map. So with anti-spike antibodies, blue is bad, red is actually good in this. And red means that you are doing it as well as an immunocompetent patient. So clearly for the patients on anti-TNF, it was all blue, meaning they struggled against all of the normal and the variants when you go to 3 months out from the second dose of vaccine. More concerningly, looking at neutralizing antibody titers, clearly patients on anti-TNFs, again, all blue, including against the Delta variant. So 3 months out from their second dose of mRNA vaccine, they have poor neutralizing ability, including against Delta variant. Similar data shown here in terms of breakthrough infections from the VA, were clearly patients on the Johnson & Johnson vaccine had the greatest number of breakthrough infections, followed by Pfizer, followed by Moderna. Again, to hammer home the point of why a booster. If you were to boost, do you boost? So this is only a couple of papers out there looking at patients with autoimmune diseases, 17 patients with rheumatoid arthritis. And clearly after a third dose, they had a boost in response. Only a couple of patients who continued on prednisone struggled to have a boost in their response. However, overall, the data is at least appreciable that you could boost. The booster guidelines for immunocompromised patients is as shown here in the US, mainly covering patients with high dose corticosteroids or other drugs that suppress your immune system, which is pretty broad. Finally, I had a last slide on, again, why we should be concerned about boosters. And this is a preprint that's out there right now on the Omicron variant, which is the B11529. And I'll walk you through this. And what it shows here is that they took the sera from patients who had 2 doses of the Pfizer vaccine, a booster dose of the Pfizer vaccine, but at about half a month out from the booster, 2 doses and a booster at 3 months out from the booster, and then patients who had 2 doses of Pfizer and had recovered from infection. In gray, you have patients with the showing the data against the Delta variant, and in red, you have the data against the Omicron variant. Clearly, you can see here, even without fancy statistics, that the neutralizing titers are poor against the Omicron variant, regardless of any of these. And it's only patients who had 2 doses of Pfizer and had recovered from infection who seem to do the best. Similar concerning data also shown for other vaccination combinations and also for some of the post-exposure prophylaxis monoclonal antibody. So with that, I'll stop. Final thoughts are, regardless of what medication patients are on, I strongly urge patients to get their vaccination. Consider booster doses places where you can, especially now that you have the Omicron variant of concern, especially for those who continue to be on steroids, immunomodulators, and anti-TNFs. Vaccines are safe, some minor short-term side effects. Generally, I suggest not to get antibodies tested for now. But down the line, this may be significant with prophylactic monoclonal antibodies. And certainly you should have your immediate family and household vaccinated. With that, I'll stop. And again, thank you, Chairpersons.
Thank you very much, sir, for taking very deep into the IBD vaccination and SARS-CoV vaccination. Dr. Arun, can you ask the question?
Yeah, thank you, Dr. Deepak. It was a very well organized data. So it was very useful for us because every day we meet IBD patients asking questions related to the vaccinations. So coming to the first question, again, it is the same from your talk. Is there is there any difference with respect to the type of vaccine and response in IBD? Though you have covered most of the things, can you give further clarification, please? And from my side, I would like to ask one more thing. Like, is there any rationale for the fourth dose or booster, or any rationale or any data for fourth dose?
Yeah, no, these are great questions. So comparing between vaccines. So again, I mean, I guess there's not obviously a master study that looks at all vaccines in the world in like one study, which would be great. But let's say comparing in different places, I think I showed data that certainly at this point, and especially I think the FDA, and I don't want to misquote, either the FDA or the CDC has come out clearly and suggested that at least in the US, the data suggests mRNA vaccines would be preferable to Johnson and Johnson vaccine. Obviously, the structure of the Johnson and Johnson vaccine is very similar to the AstraZeneca vaccine / also called Oxford or Covishield. So there is that out there. I think then I also showed that one study we have so far that I could find on Google Scholar as well as PubMed, which is actually in preprint. So it remains to be peer reviewed, from Dr. Shenoy, that looks at the AstraZeneca or Covishield, as it's called in India, versus the Covaxin, where the Covishield does better than the Covaxin. So I think if I had to kind of put all these data together, I would probably say mRNA better than the pseudovirus vaccines, which is the Johnson Johnson Covishield, better than the inactivated vaccine, which is the Covaxin. But again, as you imagine, this is like taking data from different studies and trying to piece them together. But that would seem to be generally the case. Your next question on the so third dose is a little different from booster. Booster is like you're actually waiting 6 months and giving a third dose in most cases. I'm sorry, a booster dose in most cases, versus a third dose would be maybe in patients, especially patients who are on B cell depleting therapies, have close to a nil response with 2 doses, are getting a third dose to further boost it, or patients who've had stem cell transplant therapies, things like that. So I think your question of a fourth dose, I don't think there's data to support that yet. I'm sure. So we are studying booster dose effects right now in Coveripad. Several others I'm sure are doing here, including many here on the panel. So I think we'll have to look at it further out, let's say at various time points after the booster, to really answer your question. Like for example, do patients on anti-TNF especially, do they decay again after a third dose? Our hope is, of course, that the T cell responses kick in. There's not yet good data out there about T cell response, as well as the breadth of the B cell responses also goes up after the booster. So I'm hopeful. I mean, hopefully we don't have to come to a fourth booster, but you may need annual top-ups. That's certainly possible.
Thank you, sir. So Dr. Roshan, would you like to take up the next question?
Yeah, thank you, Dr. Arun. So we have a question here. Is there a long-term data about the safety of boosters of Pfizer and non-Pfizer vaccines?
Yeah, that's a great question. I would say specific to IBD, obviously there is not. We are, in fact, I mean, booster data itself in IBD patients is not out there yet. What I presented was in patients with rheumatic diseases, and again, a small cohort of 17 patients. So I think the general booster safety data definitely is starting to, it's probably being collected right now as we speak. So again, I would say there's nothing to suggest that booster doses would do any worse than the data we saw with the original first and second dose. So I'm boosted. So I mean, I would encourage those who meet criteria to get boosted. So I mean, I don't have any concerns, while obviously the data is currently being collected.
I think we don't have any more questions now. Thank you, Dr. Deepak. It was a wonderful session. Over to Dr. Vishal for next talks.
Thank you.
Thank you, chairpersons, for conducting this excellent